We made it. Welcome, welcome. We made it to Houston. There was a few days there that were really iffy. And so the first thing I want to do is just say thank you. There were so many folks who reached out during that time. And this is emblematic of what CFHA is about. There's so many folks who independently reached out via emails. I see you in the audience. And who said, hey, I'll be there to support. Whatever happens, whatever we need to do, it's going to be okay. And so I just want to say thank you to those of you who reached out to me, understanding that I was a new ED, and also just because you just have an allegiance to this organization. Thank you. It meant a tremendous amount in those early days following the hurricane and the devastation that we all saw. And thank you to Houston for welcoming us, for being great hosts. I am so excited about the conference that we have in store for you today. I also want to say thank you to many of you who also have reached out personally to me. CFHA is really just a family atmosphere. And one of the themes that we're going to talk about today is the sense of home that we have here at CFHA. And that's expressed in how people reached out to me personally when I took on the job of the executive director. Folks really extended themselves. They started cheering for me. And I knew that they were cheering for me, but they were also cheering for us as an organization. We see great things ahead. We see some outstanding things that are going to be accomplished in the next 10, 20 years. And we're so excited to get there, and that's why we root each other on. And I certainly sensed that from so many of you as I took this role. So today, we're going to talk about the future of integrated care. But as has already been discussed, we do this in the backdrop of so much of the devastation that has occurred here in the city. And again, I just want to highlight the resilience of the people of Houston. Honestly, I didn't know what to expect when I set foot here. Our local planning committee was reassuring, and they said, it's fine, it's going to work out. The hotel was great about it. But we also know that there are a lot of people that are hurting in neighborhoods right around us. And so I just want to recognize that, and I want to recognize you as CFHA members as well, because one of the awesome things that happened right away, so my first thought when we heard the news about the hurricane and the devastation, the extent of it, of course, my first thought was a fairly selfish thought. Oh my gosh, the conference, right? But you know what? What was really cool about what happened was that the second thought was, but we're CFHA. We're full of people who run to these sorts of places. We're the kind of people who want to be helpful. We're the kind of people who go to work and choose professionally to give of our talents to those who don't have access to health care, those who deserve the highest quality care, even if they don't have the means to pay. That is who CFHA is. And that immediately calmed my nerves, because I knew that you would make it to Houston. And you turned out to Houston in big numbers. So we are over 500 attendees. That is beyond my wildest dreams. It is the second highest attendance in CFHA conference history. It is absolutely awesome. And it's really a great connection to the conference that we had in Austin a few years ago. It is, I think, building on some of the seeds that were planted at that time. We saw that today at the Texas Policy Summit and some of the advancements. Now, we're not talking about kind of global things now here in Texas. We're actually getting down to the nitty-gritty of how we do value-based payments. We've got some experiments out there already piloting specific value-based payments in different types of settings. So we're making progress here in the state of Texas, and against this backdrop, it makes it all the more rewarding. So we're going to talk about the future of integrated care, which by itself is a very overly grandiose topic. So let me just debunk anyone who thinks that I actually know what the future of integrated care is going to be. I don't have a crystal ball. I don't have any special knowledge that many of you don't have. I'm going to give you some of my best educated guesses about where this is headed as a way to kind of get our wheels, our brain wheels moving and thinking throughout this conference. But before we go to the future, as I was thinking about this, I naturally look back to the past, to our past as an organization, and then to my past personally. And so if you'll indulge me here for a moment before we go to the future, let me take you to my past. So about 17 years ago, this was between 2000 and 2001, I had a slightly younger looking face. My face doesn't age very much. Patients always ask me, how old are you? The gray hairs are helping now. But about 17 years ago, I fell into a job at a health center on the west side of Chicago called the Lawndale Christian Health Center, is what you see there. It didn't look as nice as this. This is a renovated building. It used to be a Salvation Army building and a Cadillac dealership before that. And I was fresh out of graduate school, literally. My postdoctoral year was the job that I was given at the Lawndale Christian Health Center, and I was the first mental health professional that they'd ever hired. And as such, they didn't really know what they were doing, and I didn't know what I was doing. I fell into this job not knowing anything about primary care, not having any orientation to integrated care at all. My sort of understanding was, well, I'm a psychologist, I'm going to do my psychologist thing. And again, they didn't really know any different. I was the first mental health professional they had hired, so they said, well, go do your psychologist thing. And long story short, it failed miserably. I was horrible at doing whatever it was I was supposed to be doing, which was ostensibly to help the physicians of this health center, which, by the way, was, and I think still is, the largest federally qualified health center in the country. And so they have this large panel of patients that I, as the psychologist, was supposed to build a program around to meet their needs. And, you know, because I insisted on taking out an exam room on the pediatric hallway and taking out the exam table and taking out the sink and putting in some IKEA furniture, so you can imagine what it looked like, right? So rug, accent rug, the low-slung beige couches. You know, there's a couch, actually, and then the one for me is the therapist, and then the accent lamp and the nice picture on the wall. And then I said, okay, I'm here, open for business, let's go. You know, my assumption was I was going to get overrun. I was like, there's 60,000 patients on the west side of Chicago, high-need population. And of course, you know, you guys are sophisticated enough by now to know that doesn't go anywhere, right? So half of my schedule was filled on any given day, and half of those people who were on the schedule showed up. So I was seeing 1 to 2 patients a day. So an utter failure. Fortunately, I evidenced some psychological flexibility and began to experiment with some different ways of interacting with the physicians, being in their spaces, changing the schedule around, and eventually came around to what we now know as a more PCBH type way of working, right? The point is, we've come a long way, right? I personally look back at those early days, and I remember at that time struggling because I felt so alone. I was a psychologist. I would talk to my psychologist colleagues about me working in primary care, doing this warm handoff stuff, and seeing patients in exam rooms. And my psychologist colleagues would look at me weird. They'd be like, what are you doing? What? Primary care, what? That's no orientation to that. And so we've come a a long way from that early stage of understanding of what it would mean for a behavioral health professional to work in a primary care setting. You know what was one of the most transformative things for me, though? It was a few years after starting at the Lawndale Christian Health Center that I went to my first CFHA conference. And I've been to many APA conferences, many SBM conferences before that point. And the thing that struck me when I started hanging out with you all was that I felt home. That all of a sudden I had, as a professional, an identity. I had folks who understood the kinds of concerns, the kind of things that I struggled with on a day-to-day basis in my clinic, who had the same passion around making this kind of care accessible, and who also shared the same sort of enthusiasm and energy that I felt in those first transformative days when I would walk into exam rooms and 30 seconds after meeting a patient, have that patient disclose to me things that they had never talked about with anybody else. And I knew that they would never go see another mental health professional anywhere else. And I was there. And then the same enthusiasm that I felt as I would come out and talk to the provider and see the transformation in them as they felt the relief at having the support and the direction and the guidance as to how to continue to work with that patient. That magic, that synergy is something that you guys understand in a very unique way. And that's why CFHA is home to me. And so as we look to the future, one thing that we will always preserve about CFHA is home. This should be home for you. If you are a psychologist who is passionate about supporting your medical care teams, this should be home to you. If you are a consulting psychiatrist who's passionate about supporting your primary care physicians with the best medical expertise and advice possible so that more people have access to psychotropic medications than could have if you just handled all those patients, this should be home to you. If you're a family physician or a nurse practitioner or a nurse care manager or a care manager, and you're working hard to manage a panel of patients in your panel that have depression and cardiovascular disease, if you're working on obesity, all these areas, this is home to you. So as we look forward, let's keep that word, home, in mind. So, as I said, I have no grandiose illusions that I'm going to be foretelling the future here, but let's together sort of get our wheels thinking around what the future of integrated care may look like for us in the next 5 to 10 years. And this is a quote I want you to keep in mind. This is something that as a program developer I'm constantly thinking of. We don't want to be where things are. We want to anticipate where they will be. That's what made Wayne Gretzky such a great player. He could anticipate. It's almost like the puck came to him. In the same way, I think we who work in integrated care have this great challenge. We don't want to just go where the money is all the time. We want to go where we think the money is going to be and where we think it should be. That's one of the things I've learned in my life as a program developer. I've learned to say no to things because I know that better opportunities lie ahead. So as we think about integrated care, this is my challenge to you. Go to where the puck is going to be. So let's give it a shot today. Let's think through where integrated care might take us. We're going to talk about 7 areas, and we're going to start with integrated care everywhere, with the notion that what we're going to see in the next 10 years is a dissemination of all that we've learned in primary care spread now throughout the health system. We're going to talk about the coming data explosion. We already know that our EHRs are full of data. We already know that we're not using it terribly effectively. But guess what? There's more data on the way. That's going to be a challenge for us in integrated care. We're going to talk about getting out of the exam room. Because yes, we have developed great expertise about what works in the exam room, but more and more we're going to be asked to influence patients' lives out of the exam room as well. We're going to talk about the reorganization of the workforce. We've made great strides in developing care teams and team-based models. Now, how do we support that? We're going to talk about paradigm shifts for chronic disease management. And yes, everybody's favorite topic, money. We're going to talk about at least some of the global trends that we can expect to emerge or develop in the next decade. And last but not least, we're going to talk about model wars and a new hope. Let's start with integrated care everywhere. So, in the last 20 years, 25 years, we have learned a lot about what works and what doesn't work in primary care. And what we're going to see is that core knowledge and those core principles of those models that we've learned and those principles that work within the primary care environment will begin to spread throughout the health system. We're already starting to see some of this. There are some of you here in the audience today who are working in specialty clinics. Right? You might be working at an endocrine clinic. You might be working in a obesity clinic. And what we're seeing now is that the core principles of how professionals interface in primary care, what we've learned there is being exported to those settings. Even settings where there already were behavioral health personnel, you're starting to see the concepts that we've learned in primary care get exported to those. And in recognition to that, for example, we have a task force allocated to that topic that's going to be facilitated, and we're going to get some feedback from you about how we can support the evolution of integrated care in specialty care settings. We're already starting to see as well behavioral health homes, right? So the core principles about how to integrate behavioral health personnel into primary care is now being flipped to how do we integrate medical personnel into a behavioral health setting, right? And so a lot of the same principles that we have learned about BHCs and primary care homes are going to apply to medical personnel moving into community mental health centers, for example. One of my favorite areas, because my wife works there, is the emergency department. We're starting to see folks now not just doing triage and disposition work in emergency departments, but actually looking to do intervention. And that's a really transformative thing for emergency medicine, right? Emergency medicine has traditionally looked itself as sort of, you come in, and my wife will say this, you come in, if you're not going to die, we send you somewhere else, right? They're very good at keeping you alive, is what they do. But they're recognizing, just like we've recognized in primary care, that there's a lot of people who basically try to get their mental health needs met in the emergency department. So why don't we meet some of those needs there, right? So you're seeing this spread throughout the health system. We're going to see more and more of this throughout the health system. The core principles that we've learned in primary care exported out to each of these other settings. Now, I think for us at CFHA, we're always going to be centered in primary care, but we can't ignore and we must support the development in these other settings as well. Now, the backdrop to all of that is that even if we did our absolute best at doing great integrated care work within the professional healthcare delivery system, we all know from our public health data that most of what accounts for health and the promotion of health actually is out of our control. And so that's why it's crucially important for us also, as we consider integrated care, to consider what happens in the community. And that's why more and more we're going to see work around the social determinants of health. We're going to see more partnerships to address those social determinants of health, food insecurity, housing, connections with naturalistic community organizations like churches and other social service agencies. We're going to see our institutions connected to those in different and substantial ways. So this is a spread of integrated care everywhere. Now let's talk about the coming data explosion. How many of you have smartwatches on right now? Just raise your hand. Yeah, more of you should. I'm not making commentary on your physical status, by the way. But I'm saying this as a challenge. We need to, for lack of a better way of putting it, keep up with the times, technology-wise, if we're going to keep up with some of the coming issues related to data. So I've got my smartwatch on. My smartwatch, let's see, what is it telling me right now? Because I am up here pacing a lot, I've got a lot of steps. 9,855 steps for the day so far. I've gone 4.72 miles. Let's see. My heart rate is 77 beats per minute. Not bad. All right. Now imagine all this data is getting fed to your EHR. Now that's pretty cool, right? But what do you do with it? What are you going to do with this data? Imagine, let's say that's sending data back to your EHR through a portal around my mood. And let's say I have 3 days of poor mood. Let's say I haven't taken my medication for a few days. All right? How are you going to manage all this data that's coming into your clinic? It's cool. It's great data. But how do you separate signal from noise with all of this data coming into your sphere of understanding? Now, you may think this is super futuristic, but it's not. Just a few years ago, I was involved in a study using smartphones for substance abuse patients in our primary care setting. And we basically gave patients free smartphones. They had apps on there for all sorts of different things, like it had geolocation, so if they went into a part of the city that they usually used, the phone would alert them and say, do you really want to be here? It gave them a forum to talk to folks, had CBT apps on there to help them work through any of the cravings that they had, etc. This stuff is more here than there, and our challenge here is, what are we going to do with all of this data? Now, our typical answer to that is registries. And I really like registries because I'm a data guy. But our registries at this point are not very intelligent. And they don't necessarily help us make decisions. So one of the interesting things that we're going to have happen in medicine is the influx of artificial intelligence. So there's some really cool things happening that we want to stay abreast of. For example, there are companies working actually on having your smartphone camera analyze your face for signs of depression and the tone of your voice. So if you think about the utility of this, let's say you have a patient who's predisposed to depression and you have this app on their phone and you might set it up with them. This might be part of the intervention that you work on with them. You know what? Let's just keep an eye on this. And if we have 3 or more days where the app is sending me back information that your mood is poor, I'll reach out and talk to you about that. I'll call you. Right? And that might be an agreement that you have with that patient to make it work that way. Right? That's one instance, one possibility of how this could work. But again, the challenge is, like with most technology, is we have to get out in front of it, both to learn how to manage the data and, crucially, who's going to manage that data. A lot of times we segmented that out to a care manager, but I think in the future, all the members of the care team are going to be working with data and going to have to participate in actively using that data, because it's not the care manager always who is the best person to intervene for that particular clinical issue. It may be the physician, or it may be the behavioral health person. And there's probably always going to be one person who's got to keep their eye on the data and all the signals that are coming in. But who manages that data and who makes the decisions around that is going to be a team issue. So how do we organize our teams around that? How do you huddle around that, right? Right now we huddle, but we huddle for that schedule for that day. Now we're going to have to start huddling in a very different way. This is the coming data explosion. Now let's talk about getting out of the exam room. So we've done a really good job of doing work in the exam room, but more and more we realize the limits of the exam room. Some of that is the physical limitation of getting people to the exam room, right? Especially for those of you who work in rural areas, you know how difficult this is. Patients may have to travel long, long distances to come into your clinic and to see you or the physician or the nutritionist or the diabetes educator. And so it's not always terribly feasible. So, telehealth is an obvious solution. Unfortunately, we're kind of behind medicine. Medicine is really using telehealth a whole lot more than we are. But I think in the coming decade, telehealth is going to become a big deal. Think about it. For those small practices that certainly can't afford to have a behavioral health person, how are you going to provide behavioral support on the spot to those patients? Well, what if you could, just like you do with your interpreters sometimes, Skype them in, right? And Skype them in on demand and have patients face-to-face with a qualified mental health professional or with a qualified diabetes educator. I think we're going to see more and more of this. We may even be doing a lot of this work straight into the patient's home, right? But beyond the use of technology in these ways, I think we're also going to be pushed to think about what's happening outside of the exam room. And this harkens back to the conversation about the data that we're going to be getting from patients. Because in truth, 15 minutes with a patient, I've always felt, is not enough to believe that I'm going to leverage their behavior for the next 2 months. And so if I can't get them into the clinic, I think one of the things that we're going to be pushed to do is think, how do we impact their lives outside of the exam room? How do we continue to extend the interventions that we may have started in the exam room beyond the 4 walls? And there are some simple possibilities around this, like good old-fashioned texting, right? I know for some of us, the idea of texting is, it's like, that's for young people. But the truth is that millennials are probably going to expect text from their physicians. The boundaries are different. And so the idea that we're going to deliver an intervention in the exam room and then maintain silence until the next visit in the exam room, I don't think is going to fly very much. We're going to have to be interfacing with our patients more continuously. And again, that presents a little bit of a challenge. How do we organize our work to enable that sort of continuous connection with patients beyond the exam room? Let's talk about my favorite topic, and the thing I think that I would like CFHA to do a lot of work, and that's the workforce. We have learned a lot, as I said, about the care team. We have among us here in the audience primary care providers of all stripes, nurse practitioners, PAs, physicians, family medicine. We have our behavioral health consultants out there. We have hopefully some care managers out there. We have consulting psychiatrists. And now we're starting to really see the emergence of new professionals in the care team, like consulting pharmacists. I loved working with consulting pharmacists when I was in clinic. Boy, they were such a great resource. And other consultants that are coming into the fore, like diabetes educators, nutritionists, et cetera. So we've learned a lot about how to create these care teams. My main message here is, now that we've learned about how to create these care teams, now we need to learn how to sustain those care teams. And we need to do a better job of training to fill those care teams. So, for example, we have had, by and large, for the behavioral health professionals coming into primary care, we've had to retrain those professionals. And that takes a whole lot of work. That's not sustainable. We cannot keep doing that in perpetuity. So how do we get early in the pipeline to train students? How do we influence our academic programs so that they adjust their accreditation standards to account for the presence and the importance of integrated care training in their training? And when possible, I think one of the opportunities that we have, and that I believe will occur in the next decade, is the opportunity to actually create new specialties. Now, specialization is not always a good thing, and I'm not always for specialization. There can be negative side effects to it. But in some cases, I think it can be helpful. One of the exciting, very recent developments is that the American Board of Professional Psychology has developed a special interest group, what they call a special interest group, around the specialization of psychologists for integrated care. And what's interesting to me about that, or one of the interesting things about that, is that so many of the specialties that already exist are sort of claiming partnership with this new emerging integrated care specialty, because we cut across so many of them: health psychology, clinical psychology, et cetera. And so there's going to be opportunities for this, and this is important because if we're able to create these pathways for professionals to grow up in integrated care, it promotes folks getting into this line of work at a much earlier and earlier stage. And I'm hoping that this has a trickle-down effect where the American Psychological Association, for example, has the impetus to say, well, we need to change our accreditation standards to make room for integrated care training at the graduate level, and even begin to introduce this at the undergraduate level. And my hope is, and this is certainly what I hope to do as part of what we do here at CFHA, is to encourage this across the disciplines so that these efforts are run in parallel for social workers, for LPCs, for MFTs, for every stripe out there that fills our integrated care workforce. So, train and sustain, and when applicable, specialize. Now, let me make one more important comment here about the composition of the integrated care team. And this might be one of the more important ones. One of the things that I want us to really think about with regard to the workforce is creating a fun job to do. One of the truly sad things that I have experienced in coming into the field of medicine is how much soul-crushing stuff exists in the primary care sphere in particular, but in medicine in general. And it's sad because I love my primary care colleagues. And when we're in the clinic together, we both feel the soul-crushing, stuff. It's when you're asked to see numbers, and when your work is not respected, and when you feel as if you carry this heavy burden around you and not enough support to work with it. And my concern with what we've done with integrated care is that we have sometimes not paid attention to that and then created jobs that people don't have fun with. And at least what I've found is, if you don't have fun, you don't stay. And that it would be a shame if all we did was come into the medical sphere, into the primary care sphere, and just introduce people to a place where they're just going to burn out. So we've got to pay attention in the way we design these jobs. And I don't mean just for behavioral health folks. I mean for our physician colleagues. I mean for our care managers. I've seen care managers who have the life beaten out of them because someone created a job for them at this clinic that just is not fun. It's life-sucking. Doesn't utilize their talents. Doesn't energize them. And as I've said before, if you're not having fun while you're doing integrated care, you're probably not doing integrated care. Because integrated care is awesome. For those of us who have tasted this and tasted what it feels like when it works really, really well, it's like getting hit with a lightning bolt. You feel like you have done the best possible work you could do for that physician and for that patient, and vice versa. Now, this is a slide that's intended simply to elicit patience on your part. Because the work that we're doing is going to take time. So as we develop the workforce, we're talking about generational work. I use emergency medicine. Obviously, my wife is an emergency medicine physician, and I have an interest in emergency medicine personally. I think it's one of the key growth areas for us in integrated care. So I've learned a lot about its history. It's one of the most recent specialties, actually, along with family medicine. There actually was a time when if you went to an emergency medicine department, you did not see an emergency medicine physician. You might see a psychiatrist, you might see a nurse, you might actually see a medical student, which might sound horrifying. It should sound horrifying to you now, because if you just got into a car accident, the last thing you want to see, no offense to my psychiatrist colleagues, is a psychiatrist staffing the emergency room. But that's what it was like in the 40s and 50s. You just had physicians sort of randomly staffing what was essentially the front door of the hospital. That's why it was originally called an emergency room, not an emergency department. And it wasn't until 1961 that enough public pressure and impetus occurred where some physicians said, well, wait a second. Let's just spend more time in the emergency room and do a better job at that. And so the first emergency medicine physicians were actually transplants. They were psychiatrists who decided to spend more time, family physicians who started to spend more time in the emergency department, etc. Now, from the time that first totally logical, totally reasonable idea had its genesis, from that time, I hope everybody in the room would agree, that's a great idea, right? No brainer. Let's have emergency medicine physicians specialize to provide the best possible life-saving care at the front door of the hospital, right? Anybody against that? No. It took 20 years from the time of the first groups forming until they became a boarded specialty. 20 years for an obvious idea. Now, I think integrated care is just as obvious. I think it's a no-brainer. But it's going to take us time, especially in the area of developing the workforce. And we need to be patient. We need to be thinking about the long game when it comes to our workforce and how we sustain and train and develop it. All right, let's talk about what's coming up with paradigm shifts with chronic disease management. Now, I, not too long ago, realized that for most of my career, as I was providing some counsel, basic counsel on nutrition, for folks, for example, losing weight, that I was providing guidance that wasn't terribly helpful. The basic framework of it is, and please do not criticize me for this, this was just the way that I assimilated the knowledge and highlights the point I'm about to make. My basic psychoeducation to patients was calories in, calories out, right? Basically the notion that we're a machine. If you eat a certain amount of calories and then sort of do enough exercise to expend those calories, that's how you do effective weight management. Now, if you know anything about the emerging literature on nutrition, you know that that makes absolutely no sense any longer. But that's how a lot of us were trained. We were trained to think of this sort of mechanistic, sort of reductionistic approach to food. We know a whole lot more about food and how the body metabolizes it and the complexity of it, right? So now we really have to think not just about calories, but we have to think about the content of the food, right? We were encouraging patients to have simple, whole foods. Even things related to the timing of when you eat is important as to how the body is going to metabolize that. We know that this was a fascinating research paper that I read recently, that even the flavor of the food has an impact on how the body is going to prepare to metabolize that food, which is why a lot of the sweeteners kind of trick the brain, and the brain gets a little bit confused by it. So there's some concern that maybe the artificial sweeteners are not the great benefit that we thought they were, because we were trying to reduce calories, right? Because that was our main target, calories. And of course, if you've been around or alive for the last 25 years, you've also probably been impacted by the whole idea of low fat, right? So my kids get low-fat milk at school. But the emerging nutrition science says, actually, that probably doesn't do very much for weight maintenance, right? Or healthy weight maintenance. So here's the point. The point is, in the next decade, we need to keep up with this stuff. And we need to do it more intelligently and more, we need to keep up to date, essentially. Because this stuff is coming out in droves now. Here's the good news. The good news, I think, is our care teams are much better set up than what was the case before, where pretty much it was the physician who basically had to hold all this knowledge themselves. Now we have a team that can keep up to date with this knowledge on cardiovascular diseases and some of the best strategies for managing these diseases, for working with obesity and heart disease and hypertension. But our challenge is going to be to assimilate and keep up to date with this and have the care team house this information and then figure out creative ways to do the psychoeducation that we need to do with our patients. But this is going to be an emerging challenge. Now, you may not think of substance abuse as a chronic disease, but here's a major paradigm shift in the next decade that has already started. For too long, we have considered substance abuse sort of like leprosy. You know, it's that kind of thing that other people do. Not me, I'm a mental health professional. I don't do substance abuse. I never understood that. Is it some sort of other weird kind of behavior that is different than the other weird behaviors that I work with my patients? It's a behavior. It has its particularities, but it's a behavior. And I ought to be trained to work with those just like anybody else. Well, guess what? That is the shift. So more and more, we, especially in primary care, are going to be asked and challenged to work in this area. The whole area of medication-assisted treatment is actually just the tip of the iceberg with regard to that paradigm shift. It's just one mechanism by which we are being asked to treat substance abuse as a chronic disease condition and use many of the same tools that we use for diabetes or any of the other chronic conditions that we already treat in primary care. So what that means is we have to stop thinking about substance abuse as leprosy and start treating it in much the same way as we treat diabetes and all these other, again, chronic conditions. So that's going to be another challenge for our care teams. You're going to see more of this coming down the pike. And naturally, there's a little bit of resistance, perhaps because we have some cultural feelings or taboos around substance abuse, different than we might have around diabetes. But again, I think we in integrated care are well positioned to make the argument, we can do this. We can do this if we provide the right sort of care team around the physician or primary care provider. We can do this. And finally, aging. Aging is also one of the huge areas that we're going to have to deal with in the coming decade. Now, I don't want to out myself, but I am entering midlife. And it's hit me a little bit hard. I am now in my early 40s. I feel older. Hey, that feels different than 35 somehow. You know what I mean? So I've started thinking about things a little bit differently. And I've started realizing, you know what? Each stage of life really does have its own challenges. And we need to address the challenges of each of those stages uniquely. We're going to have a huge, we already have a huge, but we're going to have an even bigger, older population to work with. And we're not just talking about chronic disease management with that. I think a lot of times we think of aging, we think, okay, we've got a lot of sick, older people. It's not just that. There's a lot of research coming out about things like loneliness and the impact, the cross-cutting impact of things like loneliness. Do we have something to say about that in integrated care? Is there a role for us in working in that very important area? So those issues, caregiver issues, those are going to be part and parcel of the fabric of our community life. And I think it's going to be more and more important for us in our integrated care environments to be sensitive to, prepared for, and knowledgeable about those issues in particular. All right, payment reform. There's no way to do this justice in any presentation of any kind whatsoever. I will say this, I was very heartened by the summit that was had earlier today, the Texas Summit. This was some of the more specific discussion around value-based payment methodologies that I have heard of really in a long time. There are actually experiments going on now, and these experiments will grow, they will develop, they will become more sophisticated, and they will expand. Here are some of the big cross-cutting themes. I know for a lot of you, you hear payment reform and you hear words like global payment and all this, and you kind of glaze over because most of you are just like, let me see the patient, right? And that's fine, but I think it's important for you to understand what's going to be changing because you're going to be the one tasked with making it happen, which is getting the outcomes that's going to make this sustainable financially for your health centers. The good news is, this is good news. By and large, this is going to be good news for us. It's going to free us up from CPT codes to actually being flexible with how we interface with our patients. That's the good news. So there's a couple of key trends that we're going to see, that we're already starting to see, frankly, across different states. And of course, this is all local. You're going to start seeing the more unified funding strategies. So traditionally, in a lot of states, you have your medical bucket of money, and you have your mental health bucket of money, and you also have your substance abuse bucket of money. And what you're going to start seeing is that money come together. And it's going to be different in every place. The problem is that money also goes along with regulatory structures. So there's a lot of people invested in keeping that money because it's basically their jobs. So in some places, you'll have incentives for those buckets to work together. That's happening in places like Oregon, for example. In some places, you'll actually see the buckets destroyed and one bucket created, right? And there'll be some pain involved with that through that process because people will lose their jobs and rules will have to be rewritten, et cetera. But without unifying the money, everybody understands that you cannot really do good integrated care because there's no joint incentives. So we're going to see more of that unification of the funding. The other thing that you're going to see as a result of that, or partially as a result of that, are more of these what are called global or bundled payment strategies, stuff that we talked about earlier this morning at the Texas Summit that they're actually experimenting with. So this can take the form of something, for example, like a per member per month payment, where instead of getting paid for seeing a patient every time you see them in the exam room or in the office, you're getting paid for being responsible for that patient. And you could see them 6 times or 12 times in the month, you're just still going to get paid what you're going to get paid. And so that's a good thing because it gives us some flexibility. Again, we're kind of freed up from the CPT code at that point. And as part of those payment strategies, there's going to be also a little bit more risk and more reward. So more reward because, as is discussed at the summit this morning, you can actually participate in saving strategies or shared saving strategies. So for example, if the payer makes money because you did a good job taking care of your patient efficiently, and you kept patients out of the emergency room or decreased hospital stays, you get to share a certain percentage of what the insurer was able to save. Or it could be shared risk. It could be, well, if you happen to not be successful, you might get dinged on that and not get paid an additional amount on top of your per member per month payment. So those are examples of things that we're going to see more and more. Now, is fee-for-service going to go away in the next decade? Probably not entirely, because fee-for-service still works for certain types of issues. So we're going to probably see a blending and a hybridization of a bunch of these strategies until we kind of come to some sort of homeostasis around payment. But there's going to be some big changes in the next decade in this area. And last but not least, I was going to have the Star Wars music for this, but then I was like, no, This is what I'm predicting for the next decade here. If you have participated in our listservs, you know what I'm talking about. The rest of you are like, what is he talking about? So we have spirited discussions at CFHA about models, whether we need them or not, which are better, which are worse, you know, those sorts of things. So here's my prediction, and maybe it's more of a hope, but I actually do think it's a prediction. I think we're getting more sophisticated around our models, our understanding of models, the core principles behind those models, the importance of models and the limitations of those models. And I think that sophistication is going to help us in the next 5 to 10 years come to a sense of understanding. And that's going to lead us to peace in the integrated care galaxy. I'm going to, in a future slide here, explain why I think we argue as much about this as we do. But before that, let me give you an analogy to work with that maybe gives you a little bit of my understanding of how these things kind of come together. So if you think about each of the models and you think about what they're trying to solve, you begin to understand how they are different and also how they are complementary. So if you think about PCBH, I think of PCBH, the PCBH model, as more of the pipeline, right? So it's answering a very fundamental question. What is the best way to integrate a behavioral health person into a primary care or medical setting? What's the best way to do that? Because we need to get behavioral health support into primary care because we have patients who are showing up there who need that sort of support, and our physicians and our primary care providers need that support. So it's answering a structural question, right? Because we know from prior experiments that getting patients to specialty medicine hasn't worked real well. And so I think of PCBH as more of the pipeline. It's an infrastructure issue. And so two of the major innovations of the PCBH model have been simple. I think they're actually obscenely simple. It's just really the role of the psychologist or the social worker or the LPC or MFT in the medical setting and giving them a consultant role, kind of a particular role on the team. And I think that's one of the innovations that has really changed the way we think about mental health professionals operating in a primary care sphere. And the other innovation has been the warm handoff. It's just the idea that if we rearrange their schedule and make it more flexible and make them more accessible to the primary care team, they become more a part of that primary care team. There's a synergy that emerges there that is very different than a specialty co-located therapist, right? So that's the pipeline. It solves a pipeline issue. Now, you compare that to the collaborative care model, and I think of that as more sort of a clinical intervention. It's more the substance of what comes through the pipeline. It answers a different question. It answers the question, well, what's the best way to track our patients with depression and hypertension and other sort of chronic diseases, right? And so some of the major innovations there have been the development of registries, although collaborative care didn't invent registries, they certainly leveraged registries really well, and also the role of the consulting psychiatrist, which has been a tremendous benefit to so many of our teams. So it's a lot more answering the question of what's the best way to do good depression care, and more, again, chronic disease management as well. And then we have our family and systems perspectives, which I feel like cut across everything that we do, or should cut across everything that we do. And again, this is cutting across, it really is attending to our interventions. Do our interventions consider the person in context? Do they consider the familial, generational, community-based factors that we need to attend to if we're going to actually promote substantial changes in health? And similarly with the expert clinical pathway, there we're answering the question, well, what's the best way to provide substance abuse care in a primary care environment? How do we do that? Well, motivational interviewing is one of the key strategies there, and making sure that we're screening for folks. So the reason why I think there's going to be peace in the integrated care galaxy with all of these perspectives is simply because if you understand that they're answering different questions, you understand that they can coexist. In fact, in many ways, should coexist. So my old clinic in Madison, Wisconsin, 10 years ago, we started out with the PCBH model. But then we started realizing, you know what? How are we going to care for our patients with depression effectively? So we developed a registry to track those patients with depression and other issues as well. And more recently, the clinic has implemented screening a la the expert model and used our BHCs to provide the motivational interviewing for those. And because I don't think you can be a good BHC and ignore the cultural, familial context, the community context, our clinic also said we need to consider the systems in which our patients are living and address those. So we did social determinants of health screening. We started screening for ACEs. So in one clinic, we had each of these perspectives contributing substantially to our work. And we're going to see more and more of this, I think, in clinics across the country. I get more and more questions about this each day from people asking, how can we incorporate this into the work that we do? Now, why do I think we sometimes wrestle with each other? Which, by the way, is not a bad thing. I like the wrestling. But I think we ought to know why we wrestle. Well, we wrestle because integrated care is big. And there's a lot of work to do. And there's a lot of work to do all over the place. Some of us are involved in reducing transition of care issues. Some of us are working on the access to behavioral health care. Some of us are trying to increase access to prescribers of psychotropic medications. Some of us are working on the social determinants of health, etc. We're working in different spheres. And I think that's awesome. I think that's what CFHA ought to be about and will continue to be about, the breadth of what integrated care can do to transform the healthcare delivery system. However, what I will reject is this, the scarcity hypothesis. I think one of the things that happens sometimes is that we buy into the notion that we're working in a scarce and barren landscape called healthcare, that there's not enough resources to do all the work that we're doing. And then we kind of might turn on each other. Or we might say, well, my model's better than your model. Or my area is more important than your area. This only occurs if you buy into the scarcity hypothesis. If you believe that there are such limited resources that only one thing can be attended to. Right? Well, call me an eternal optimist, but I don't believe in the scarcity hypothesis. In my career, I've seen the opposite. This goes back to that idea of fun. When you have fun at what you do and you infuse passion in the work that you do, what you find is that resources come. What you find is that where you thought there wasn't space to do the work that you needed to do, that space gets created because of your passion, because of your drive, because you're willing to extend yourself. We have come a long way in the last 15, 20 years, 25 years. Look at all of the pieces of the integrated care team that have emerged in that space. Now, this has happened at a time where there's also been so much change and so much adversity in the healthcare environment. But because we put passion behind this work, because we believe that having a consulting psychiatrist really improves care, and even despite the fact that we don't get paid for all that work the consulting psychiatrist does, we still move forward. Because of that, we created opportunities. Those opportunities then created space for new possibilities to emerge. So I reject the scarcity hypothesis. This is the way I see the world. You bring your passion, the world will return that passion with opportunity. Here's the other reason why I think I don't believe in the scarcity hypothesis related to healthcare. Because during this same time that I have grown up in integrated care, you see that chart? I keep getting told that we're spending too much money for healthcare. And in fact, we are. We are horribly inefficient. And part of what we do here at CFHA, actually, with integrated care, is really working towards spending our healthcare dollars more wisely. But you know what? We live in the richest country in the world. We have the money to spend on healthcare. What we don't have is that money distributed appropriately. That's the challenge. It's not having enough, it's not in the right places. That's the challenge. So if you frame it that way, you begin to see, well, we have ample resources. Scarcity is not the issue. It's how that money is allocated. So at the same time that we see this increasing costs, Wall Street seems to think that insurers are going to be just fine. This is actually very recent, October 13th. So these are very recent stock-related valuations. All right? And I'm not saying anything bad about payers here. I'm fine with payers making money. I'm fine with people making money. But I reject the scarcity hypothesis. We have what we need. We just have to make the argument, and we have to bring our passion, and the opportunity will come. The great thing is that there's no turning back. I really fundamentally believe that. We here at CFHA, I think 5-7 years ago, I might have said, you know, this integrated care thing, it's a little bit on iffy ground here. But no longer. Enough of us has tasted the passion, the energy. Enough physicians have said, I will never practice without a BHC at my side, or a consulting psychiatrist at my side, or the support of a care manager, or a clinical pharmacist. We have tasted it. We are not going back. There's enough payers who have seen the light. There are enough government officials who, despite all the tumult of what's happening in Washington, D.C., have not turned their back on integrated care. There is no turning back. So, as we end here today, indulge me for a moment to connect this back to CFHA. I hope in what you have heard here, you see a little bit of the future of CFHA and where we're going to move forward. We have ample opportunities all over the place, and you are the ones that are going to drive that. Now, you've seen some of the initial changes that we've made, some of the efforts that we've made to highlight what CFHA is about and how we participate in the integrated care movement. You've seen our new webpage, and you've seen highlighted there the technical assistance piece. That's because we're passionate about workforce development. We want to build the future workforce and the workforce centers. And we want to be a part of that and setting the standard around what good technical assistance looks like. We also have a new feature called forums. It's not going to replace our listservs, but it's a new place where you can go there, and different than email, where stuff can sometimes get lost, we can have things on a more sort of permanent searchable basis on the website, so that when new people come on and they ask that same question that's been asked 25 times on the listserv, so how do you do this warm handoff thing? You can go and search that up. In fact, one of the forums that we have is a best of listserv forum. So we're going to be copying and pasting some of the best conversations that we find on the listserv, put them on there so that people don't have to necessarily ask the same questions. Although, if you're new and you need to ask the same question, go ahead. Somebody will very kindly answer the question for you. You've also seen our new conference website, and every year you're going to go back to the same website, integratedcareconference.com. And so next year, actually in 2 weeks, you will already see the information up for the Rochester conference. That is going to be absolutely awesome next year. It'll be our 20th conference in a historic place for our organization, the birthplace really of CFHA. So integratedcareconference.com. And now I'm proud to announce our newest website. It's still in development, but I'm going to tease it today. It's called integratedcarenews.com. It's going to be part of our family of websites powered by CFHA. And on this website, what we're going to have is aggregated the best news, information / hopefully some entertaining feature to it, including a brand new effort that you all will learn about called our podcast. We're going to be asking you to send in your 60 seconds of discussion or some 60-second recording of integrated care, because we want you to essentially apply to be a co-host on our podcast. This will be a monthly podcast. It'll be a way for you, those of you who work in rural settings, who drive long distances to get to work, you can pop in your phone and listen to CFHA folks talk about the latest and greatest related to integrated care. Now, why are we doing this? Why highlight integrated care news? Because a major function of CFHA is to tell your story. I am passionate about the work that you do. What I want to do, what we want to do, is share your story with the world. I can look around this room, I see your faces, I know the stories of what you've done. I know the stories of what you're doing in Philadelphia, and that the world needs to hear about what you're doing. Or in Newark, I know the stories you're doing in Oregon and in Washington. There are great stories out here that no one or very few people know about, and that bothers me. That bothers me because I want everybody to hear the great work that you're doing. So we need a channel, we need an avenue for telling those stories. We're moving our blogs onto that to make it a more beautiful place to read, and to read Matt Martin's work and to read many of the other bloggers that contribute to that blog, to tell the story of integrated care, to keep moving the needle forward. This is integratedcarenews.com. Look for it later this year. CFHA is a participatory organization. This is not about one person, so these are opportunities for you to get involved and to contribute content for us and to contribute the great stories of the work that you are doing. So, I apologize for taking us a little bit over time here today, and I apologize especially that we did not have enough time for questions. But I will say, one of the great things about CFHA is grab people in the hallway, including myself. If I've offended you with anything I said, grab me in the hallway and talk to me. But this is my encouragement to you as you leave. Do that for all the presenters. If you've had a presenter prepare a presentation up there, they want to talk to you. That's what they prepared their talk for, to have interaction. And that's what we do here at CFHA. We have great hallway conversations. I will say this time and time again. The thing that I came back for to CFHA was not the sessions. Sessions are fine, they're great. Plenary sessions had boring speakers like me. That's fine. What I came for were the hallway conversations. So that's really where the action is going to be. So take advantage of it. Last but not least, let me entice you for tomorrow. We have got a great plenary speaker coming up, much more interesting than me. He actually knows what he's talking about related to the future of healthcare and healthcare payment reform. Len Nichols from George Mason University is going to be here to talk to us. And he's got literally the latest up-to-date information. This guy has been updating his presentation to the last second with all the changes that our craziness in Washington has introduced into the healthcare sphere. This guy knows what's happening, and he's going to tell us about it tomorrow morning. So be here bright and early. It's going to be a great time to get up to date on what in the world is going to happen with the Affordable Care Act and with healthcare in America. CFHA, thank you so much. Have a great conference.